Good morning, everyone. My name is Rick Barfoot. I'm a grad student in management sciences, and today I'll be talking about data sources for syndromic surveillance systems. I'll start with an introduction and motivation behind syndromic surveillance, followed by a description and definition, talk about some of the areas that are addressed. I'd like to touch a little bit on the literature review that I've done, discuss some of the progress and activities to date in this area, as well as some of the current research and development that's going on. I have a few examples of computer science problems to be solved in this particular area, and then I'll finish up with my own insights and reflections. Just as an introduction and a backdrop, here are three examples of influenza outbreaks in the past century. Specifically, the first one, the Spanish flu, occurred in 1918, 1919, caused approximately 500,000 deaths in the U.S. alone. It was estimated to cause 50 million deaths worldwide. Now, to put that into modern-day context, if a medium flu pandemic was to occur, or when the medium flu pandemic occurs in the U.S., according to the Centers for Disease Control, it would cause between 100 and 200,000 deaths. You can see some of the other numbers here. Total cost to the economy between $100 and $200 billion. These are stats for the U.S. only, not talking about worldwide. To put it into local context, this is the output from a model put together by the Ontario Ministry of Health, which predicts what the additional death toll would be in Ontario due to the next flu pandemic. So you can see this is the 5,000 deaths per month is the normal rate of death in Ontario. The red bars indicate what the additional rate would be in each given month following the outbreak of influenza. So what is syndromic surveillance? First of all, talk a little bit about what a syndrome is. A syndrome is simply a collection of symptoms which characterize a disease. So here are some very common symptoms: rash, fever, vomiting, headache, sore throat, and cough. Now, taken alone or even in combination, most of the time they're not lethal. I mean, they're very common type symptoms. However, when they are taken together, then they can characterize certain diseases. So rash, fever, headache might indicate smallpox, fever, vomiting, headache, anthrax, cough, sore throat, and fever, influenza, as an example. The first two being types of infectious diseases that we would expect to have been released by terrorists. Influenza is one that we would expect to be released naturally. Now, these are just three examples. There are hundreds of different types of infectious diseases that could spread through the population. So the syndromes characterize to some extent the disease. Does that mean that you have smallpox if you show these three symptoms? No, of course not, luckily. In fact, the chances are that you don't. However, what syndromic surveillance attempts to do is to monitor these symptoms that are happening in the population, and it tries to detect an outbreak of these types of diseases before traditional methods, such as a clinical diagnosis of the disease, would happen. Why would we want to do that? Why is it important to detect early? This is taken from a study that's a hypothetical scenario of a release of inhalation anthrax on a population of 100,000 people in the U.S., so similar to the size of Waterloo, let's say. And they've taken everything back to the number, to a financial cost. So they've translated number of lives lost and human suffering and lost wages, et cetera, combine it back to a number. So the top curve here is showing the cumulative impact to the economy after 7 days of release, if there was no response, no detection and no response, versus the line here at the bottom that's showing if it was detected within the first day and a response was immediate and effective for the whole population, what the cumulative impact would be. So you can see that there's quite a difference. The steepest part of the curve is representing $200 million per hour. So you can see that being able to quickly detect an outbreak as soon as possible really comes down to a matter of minutes and hours. Shows a conceptual overview of a syndromic surveillance system. This is based on a specific system called RODS, Real-Time Outbreak Disease Surveillance. Basically, we're looking at a data feed of different types of symptoms and syndromes occurring in the population. Those are collected by a data collection module, classified into certain types of diseases, possible diseases, rules and algorithms working in conjunction with control limits will signal an alarm if certain levels are reached. Now, that alarm is typically something that's monitored by a public health professional, a public health agency, and at that point, someone will become involved and would actually start to investigate, is there really a problem here, or is this potentially a false alarm? Okay, so it's not automatically going to set alarm bells going for the whole population. Some of the areas addressed very quickly in general, syndromic surveillance touches on epidemiology, signal detection theory, and decision theory. And specifically the element that I was looking at, the data feeds, additional data feeds, talking about looking at natural language processing and information retrieval. I started my literature review at the RODS lab website, which is the University of Pittsburgh. That's where most of the research is happening right now. It seems to be a nexus of information. So I started with some of the papers there, and I actually used a lot of the references in those papers as well to get more background information. Those papers in general are heavily referenced in the literature that's available, as well as by organizations such as the Centers for Disease Control and the Public Health Agency of Canada. Some of the activities to date, there has been a lot of activity recently within the past 4 or 5 years, especially after 9/11, but even leading up to 9/11, there was a lot of activity. There is the real-time outbreak disease surveillance lab at the University of Pittsburgh, as I already mentioned. That's a hub of activity. The U.S. Department of Defense is quite interested in this. The Public Health Agency of Canada is looking at implementing this system actually in Canada. And in terms of the data sources that are in use today, already used, being fed into RODS as part of that big data feed, emergency room chief complaints. So when patients or people show up at the hospital and they're complaining that they're not feeling very well, and they explain to the doctor what kinds of symptoms, or the doctor observes certain symptoms, even if the doctor isn't able to clinically diagnose on the spot what the problem is, maybe he has to send away for a lab report, at least they can log all of the symptoms. And again, the idea is that before something is clinically diagnosed, just based on the symptoms, and if there's a lot of activity, a lot of people in the population that are manifesting those symptoms, is possible to have this early detection. The other one that I'll go into more detail about is over-the-counter pharmaceutical sales. So monitoring, if people are buying antihistamines or antidiarrheals, if there's an increase in activity there, that could be a good indicator that there's something happening in the population, that there may be an outbreak. And I'll talk about preliminary work in the area of internet data usage. Briefly, RODS was developed in the late 90s by the University of Pittsburgh. It was first released as bytecode for non-commercial use, and it was later released as open source under the GNU GPL license agreement to get the quickest and the widest spread that they possibly could, and adoption that they could. The current data sources, I've already mentioned these briefly. It turns out that when you're starting to feel under the weather, it's not surprising you start to display some symptoms, runny nose maybe, or you feel nauseous or vomiting. Very few people actually go straight to the hospital. First of all, most people will go to the drugstore and try to, or go to their drug cabinet and try to self-medicate and get over the symptoms. Using over-the-counter drug sales as an indicator, this particular study was looking at the correlation between sales of electrolytes for children, basically, like Gatorade and that sort of thing to rehydrate children, and the actual clinical diagnosis of diarrheal disease or infectious diarrheal disease. So the red line indicates the actual clinical diagnosis over time, and the orange curve represents the sales of electrolytes. So you can see that there is some sort of correlation, or seems to be at least. This particular study found that on average across a number of different cities, there was almost 2.5 weeks of warning based on the electrolyte sales that there was something happening in the population. So one of the big current R&D opportunity for syndromic surveillance systems, as identified by the RODS project team, are looking at different data sources. One of those potential data sources is the internet. So we've seen already some people go to the emergency room. We can collect that information, but it's a very small percentage. Most people go and buy things from the drugstore, and that's already in place, and all of that data is being fed in. The question is how many people are actually first going to the internet, or at some point in the process, maybe after they get some medication, are going to the internet and trying to diagnose what the problem is for themselves. And how can we capture that? There are two basic ways, two ways that have been identified until now, at least, for capturing that type of information. The first is by tracking page hits, and the second is by monitoring web queries. So in the case of page hits, we can look at the web logs. It's information that's already captured. can look at the web logs and see what is the activity to a certain page or a certain disease page. Here's an example of West Nile. So how many people have gone to that West Nile page to look at, what are the symptoms, what are the causes, how can they prevent it, how can they cure the problem or treat the problem themselves. This is at the Centers for Disease Control site. Even going a little bit further, trying to have an even earlier detection, moving upstream, would be looking at the queries. So how did they get to this page? Is it something that they saw in the news and they just wanted to find out about West Nile? Well, that doesn't really help us. That doesn't really indicate that the person might have a problem. But if they were typing in something into a web query, into a search engine such as fever and headache and rash, that could provide a very good indicator that there's a problem. In this case, that particular query would be a better indicator of anthrax than someone actually typing in and searching on anthrax for the exact same reason. Maybe they just saw something on the news and they're interested in anthrax. Whereas in this case, they're actually typing in their symptoms or, let's say, the syndrome. So how can we capture that information? How can we make use of it? Examples of internet data sources that already exist. The Centers for Disease Control, the World Health Organization, health and medical websites such as WebMD and Dr. Coop, and even global search engines possibly at the very top of the pyramid, talking about looking at monitoring queries through Google and Yahoo. The advantages of using the internet data as a source for syndromic surveillance, first of all, it's potentially a very early indicator, as we believe that with internet trends and with the trend of Americans, in particular North Americans, to try to self-diagnose, a lot of people go to the internet to try to find out what the problem is first. And even if it's not for themselves, maybe they're checking for someone that they're living with, one of their relatives, et cetera. The data is already collected, and there are relatively few data sources out there that need to be consolidated. So there's a huge potential for using this type of information. Some of the issues with it, however, are, first of all, proving that it is a good indicator, because that hasn't been done yet. So this is really sort of leading-edge research. So proving that there's a signal there that can be found, that's the number one thing, because there's no sense going farther unless we can prove that in the data somewhere there is an indicator. Matching the requester IP address, so where the person has come from, to geography, that's also a very important part, because there's no sense detecting something if you can't target the response. You need to know where the person physically is located. There's not very much research in this area at the moment. Again, University of Pittsburgh, the Rods Lab, there is one individual working there that I've been in correspondence with. She has published a study on monitoring page hits via web logs. The study wasn't conclusive. She didn't come to the conclusion that absolutely we can start to use this information, but it did look promising. And the conclusion actually was that with more data and different data sources, that there's still a huge potential. There is currently an investigation of using the web queries as well. Some of the areas of CS or CS-type problems to be solved, data mining, so filtering of very large data sets. You can imagine the billions and billions of queries that run through something such as Google or Yahoo every day. Being able to pick out just the ones that we're interested in that may indicate syndromes is a huge effort. Natural language processing as applied to parsing of the web queries into something that's useful and efficient to process. As well as classifying those symptoms and keywords into specific syndromes that can then be used as part of the surveillance system. And the last one I already mentioned, tracing the requester back to specific geography. Here's some of my personal insights and reflections after doing this research. This area, I think this area has a huge potential, syndromic surveillance in general, and specifically using data sources from the internet. It absolutely has a huge potential of saving millions of lives and billions of dollars. But there's no question about that. There's a huge focused effort in this area right now on both sides of the border, Canada, the U.S. And the interesting thing is that I didn't have the impression that there was anything that we're fundamentally missing. We're not waiting for any theoretical or technological breakthroughs to be able to start solving these problems. It's taking what we already know, what we already have, and applying it to this specific problem. Despite the recent efforts, unfortunately, it may be too late by the time that the next pandemic arrives. So this may or may not be in place. I believe they've made a lot more progress south of the border. We've started in Canada to implement and deploy the system, but it's going to take some time. And whether the avian flu hits us first or not will we'll have to see. Hopefully not. And I'd like to take your questions now. Thank you.
Questions, comments? I'll give you one. How did you validate that that there was not any research beyond the University of Pittsburgh? What process did you use to do that related to the internet?
For the internet data sources? I guess I sort of relied on the information that I got from the lab group there. So I was in contact with one of the leading experts in this area, who's one of the leaders of the RODS project. I asked him specifically if there had been some research in this area, and he directed me. The only one that he knew of was the one that his colleague had worked on, and he directed me to her. I was in contact with her. I read her paper, and actually one of the statements that they make at the very start is that there's very little, if any, research in this area. There's very few published studies. This is a report that was just released at the end of last year. So I guess to some extent I was relying on that information.
You said there's work done in Canada, but you haven't really specifically said what's being done in Canada. Because mostly that's something going through, but there's still efforts in Canada.
What they're doing in Canada is the Public Health Agency of Canada is investigating deploying RODS, this surveillance system, in Canada. So they have a number of, I think they have 4 counties or 4 health units that they're planning to deploy in, but they're still in the pilot stage, evaluating, whether it's going to work in Canada or not. They're also working on specifically some very specific aspects of RODS and improving them. So one example is using natural language processing to take the emergency room chief complaints that come in and be able to translate those into specific syndromes that can be used downstream. That's all the effort that I know of that's going on in Canada at the moment. Mm-hmm.
The data gathering at the drugstores, is that real time?
The what, sorry?
The data gathering at the drugstores. You said 74% of the people go to the drugstores.
Yeah. You mean is the drugstore is the over-the-counter drug sales, is that monitoring real time? I believe it's very close to real time. So in the U.S. they've already deployed what they call the National Retail Data Monitor, and there are 20,000 pharmacies that are all hooked up into this thing. And because they're just using sales data that they would normally transmit to head office or whatever, they feed that into a centralized database that gets all consolidated and fed into RODS. I don't know what the time lag is, but my understanding is that it is almost real time. It's a very short time lag. Otherwise, it wouldn't be useful at all. Any other questions?
No, Rick, thank you very much.
Okay, thank you.